Podcast w głowie się mieści. Hello, it's Wrap Your Head Around podcast, and today with us is Dr. Judith Beck, and Dr. Judith Beck is president of the Beck Institute for Cognitive Behavioral Therapy, beckinstitute.org, a non-profit organization that provides state-of-the-art training in cognitive behavioral therapy, CBT, and recovery-oriented therapy, CTR. The Beck Institute also offers certification in CBT and online courses on a variety of topics, in addition to conducting research and providing CBT resources around the world. Dr. Beck is also a clinical professor of psychology in psychiatry at the University of Pennsylvania. She has written over 100 articles and chapters, workbooks, pamphlets for professionals and non-professionals, and 7 books including Cognitive Behavioral Therapy, Basics and Beyond, 3rd edition, 2021, and Cognitive Therapy for Challenging Problems, What to Do When Basics Don't Work. She has made hundreds of presentations nationally and internationally on various applications of CBT, and is the primary developer for the Beck Institute's on-demand CBT training courses, which have been taken by more than 28,000 health and mental health professionals in over 130 countries. Dr. Beck also provides supervision and treats clients. So hello, Professor Beck. It's an honor to have you here with us. And thank you so much that you joined us today.
Yeah, thank you for inviting me.
And it's truly honor to have such a distinguished guest with us, and like your contributions to cognitive behavioral therapy and your extensive work in the field have inspired countless therapists around the world, and also including myself. So it's a big honor to have you here with us. And at the beginning, I'd like to start by asking about your unique perspective growing up, how it was grown up with a father who is a legend and the creator of cognitive behavioral therapy. Would it be okay that we start from this question?
Oh, of course, yes. So I didn't know that there was anything particularly special about my father when I was growing up, although he had written at least one book, I think probably at least 2 books before I left for college. The first sign I had that maybe my father was well known and had done important things happened when I was a freshman in college, and I was taking a psychology course with Professor Martin Seligman, who passed out a copy of the Beck Depression Inventory to every student in the class. There were about 200 of us. And then went on to talk a little bit about my father and my father's work. So that was the first sign. The second sign came a couple of years later when my father had laryngitis, and so was unable to give a speech to thank the Philadelphia Society of Psychologists, although he's a psychiatrist, to thank them for giving him a special award. And the president of the society, before he bestowed the award, talked about my father and all of the reasons why my father deserved this award. And he said so many things that I really hadn't known before. So that was my introduction to my father as a more prominent person than I had known.
I guess that he inspired you, that you start to like interest in the psychology and psychotherapy, or because this is something that comes into my mind at like at the moment when he inspired you at the time. So maybe it was the your motivation to like start and read psychological books, or how it was that?
So that did not happen, because ever since I was about 6 years old, I wanted to be a teacher. It's not that I didn't want to follow my father in his profession. It's just that I always loved kids. And I think I was really kind of a born teacher. And so
Yeah,
I studied that. And I also studied some psychology as an undergraduate. And then I got a master's degree in psychology and education. Um, and I always thought that I would uh, want to keep on working with kids. But I realized that if I wanted to be more than just a classroom teacher, if I wanted to do something to kind of expand what I was doing, then I would need another credential. So I decided to go back and get a PhD. And again, I studied both education and psychology. And as I was studying psychology, I became more and more interested in it and more interested in my father's work. I had an interesting automatic thought, though, which was, how could I ever learn how to be a therapist? And the reason I had that thought was because I never really needed anyone to teach me how to be a good teacher. I think I would use my intuition, and I was naturally skilled at being a good teacher. And I didn't realize that there was a set of skills that people could learn to be a good therapist. And so at some point, I decided, no, I really would like to give psychotherapy a try, and specifically cognitive behavior therapy. But it took about 5 to 10 years to become to be able to use my intuition to become a really skilled or a more skilled psychotherapist. Now, what's interesting is that although I still see patients and I do supervision and I do obviously a lot of writing and so forth in the field of psychology and about CBT, mostly what I do is to be a good teacher. And so I've written some of the basic textbooks on psychotherapy. My dad and I opened the Beck Institute in 1994. We're about to have our 30th anniversary in a couple of weeks. And we have, I've really made that into an international training center. So I've come full circle, still do a lot of teaching, but specifically in the course of psychology.
Yeah, so it was like your purpose to be a teacher, and you like have those things like mixed together, like one, the part of being a teacher, but now the teacher of the cognitive behavioral therapy and in general in the therapy with the therapeutic work. Yeah, so
right.
Yeah, it's amazing. Does the behavioral cognitive approach it was always been the closest to you, or like you have some because of your father? Like I think that this is something that comes first, the CBT. But is it was like always for you CBT, or like you've been interested in like maybe studying or like also other modalities?
So I've always been primarily interested in CBT, but I think that people, including myself, really need to become highly knowledgeable about other evidence-based treatments. And one of the emphases in the 2021 version of CBT Basics and Beyond book is how to integrate techniques from other modalities. And so there wasn't room to have to put a lot in that book about it, although I'd like to do some more writing about it. But I did talk about how to integrate some acceptance and commitment therapy principles into CBT, also dialectical behavior therapy. Oh, there it is.
The third version, yeah, it's already in use. I don't want to give it closer to the camera because a bit overused because I read it a lot, but yeah, but there's a lot of like new things and
yes, I also I think I have a whole chapter on mindfulness in that book, but we also draw on techniques from other modalities that I didn't talk about: compassion-based therapy, schema therapy, interpersonal psychotherapy, positive psychology, solution-oriented cognitive therapy. So while CBT has always been my primary focus, I have for a long time thought that it was very important to study other kinds of psychotherapies and then integrate them into cognitive therapy and use their techniques when the cognitive conceptualization of an individual client leads you to believe that there are techniques from other modalities that would be effective for this particular client.
Yeah, but everything starts in CBT, like the hallways are into the cognitive behavioral approach. Were there any moments in your professional and academic life that you would consider as pivotal or crucial? If so, which ones would be the most important moments for you?
I think the most important moment occurred in the early 1990s. This is when I was still at the University of Pennsylvania and doing a lot of supervision of other therapists before we opened up the Beck Institute. And as I was supervising, and these were usually experienced therapists who just didn't know CBT very well, and sometimes they were newer therapists as well, I kept on thinking to myself, oh, isn't that interesting? This person doesn't seem to know the difference between an automatic thought and an emotion. So that's something they really need to learn. Or I might think, oh, that's interesting. This person doesn't know the difference between the thoughts that pop up into people's heads, their automatic thoughts, and their beliefs, which they may never have really put into words anymore. In other words, in the course of supervising people, I saw the difficulties that therapists were having. And at some point, it occurred to me, gee, these people have read some of the basic books in cognitive behavior therapy, but they still don't seem to understand exactly how to conceptualize patients, how to structure sessions, how to help make sure that clients are able to do their self-help assignments between sessions. Maybe there needs to be an even more basic book. And so I had been taking notes on things that therapists had difficulties with. And then it was just a matter of organizing them into chapters and figuring out a kind of a logical sequence of skills that people needed to learn.
So it is connected probably with my next questions, maybe not only one, because one is about, in your opinion, what is the heart of CBT? Like we've been talking about the concept, cognitive conceptualization. So this is what for me comes to my mind. And what are the key skills of a CBT therapist? So it's a good bridge to that question, I think.
So the cognitive conceptualization is extremely important. So therapists need to ask clients questions perhaps about an upsetting situation in the previous week, or something that something that might be coming up in the next week, and then find out what specifically was that situation. What were the patient's automatic thoughts? How did the patient then feel, and what did the patient do, especially if it's an anxiety patient or a medical patient? Did the patient have certain physiological reaction? And then it's important to figure out what are some of the themes that we hear in this particular patient's automatic thoughts over and over and over again, because those themes are related to the basic way, the core beliefs that the patient has about himself, his world, and other people, and the future. Then we want to understand how it is that the patient developed these beliefs, particularly if they're quite negative and long-standing. What happened when this patient was a child or a young adult, particularly? Um, what were some of those experiences that they put a particular meaning to? And that meaning is really what their core beliefs are. And then how have they coped with these difficult core beliefs all their lives? So it's very important to figure out the conceptualization both in the here and now of things that are problematic for the patient today, and also what kind of the background is, why it is that patients are having these kinds of automatic thoughts. So cognitive conceptualization is absolutely key. The other element that's completely essential is having a good therapeutic relationship with the patient. Now, unfortunately, I don't know how it is in other countries, but in the United States, there are a number of therapists who believe that cognitive behavior therapy doesn't particularly value the therapeutic relationship. And to me, that's just ridiculous. If you don't have a good relationship with the client, why would the client even come back to the next session? Why would the client cooperate with you and collaborate with you? Why would the patient feel comfortable enough to tell you really the truth of what's going on and what her experiences are and so forth? And there are a number of things that CBT therapists should do to develop a good relationship and also to prevent problems from arising in the relationship. But CBT therapists also need to be very good at recognizing when there has been a rupture in the relationship, and then need to learn what to do about the rupture to heal the relationship so that the client will come back and will continue working with you. So I would say those two things are the most important. A third thing, which needs to be different sometimes for different patients, like if we're dealing with patients who have been hospitalized for 30 years, it would be very different from if I'm seeing a depressed patient in my office who's only been depressed for a few months. But particularly with outpatients, the structure of the session is important, only because it's the most efficient way of getting things done. And so there are a number of things we want to do in the beginning of the session. We do a mood check. We want to find out what's important that happened between last session and this session. We want to ask for positive things too and help patients draw positive conclusions about those experiences. We want to set an agenda. We want to know what problem or goal the patient wants to address in the coming session, for the rest of the session. And we want to find out what the client was able to do in terms of self-help assignments or action plans between sessions. What did they learn from those experiences? Then in the middle of the session, we wanted to talk about a specific problem or goal. And we want to do a cognitive conceptualization about that. We want to figure out where to start working on this with the client. Do we need to do some problem solving at the situation level? Do we need to address the automatic thoughts the patient is having? Do we need to teach the patient emotion regulation skills? Does the patient need behavioral skills training? Does the patient need to know how to cope with anxious sensations that they're catastrophizing about in their body? So we do a cognitive conceptualization. Collaboratively, we decide with the patient where to start working. We might work at one of those levels or all of those levels or someplace in between. And then before we move on to another problem or goal, we ask the patient, what do you want to remember that we just talked about? And we want to make sure that anything that's important for the client to remember is written down so the client can read these therapy notes every day. And if the client hasn't already said it, it's also important to say, what do you want to do about this problem or do toward this goal this week? And then how likely are you to read these therapy notes? How likely are you to do this behavior that we've just collaboratively decided that you're going to do? And if it's client says less than 90%, then we either have to change the assignment so it's easier or make it optional or find out what's going to get in the way. Usually there's some practical problem that might get in the way, or the patient has some automatic thoughts that might get in the way. What's also really important at the end of the session is to ask for feedback. What did you think about today's session? At the beginning of treatment, we probably will also ask in the first few sessions, was there anything that bothered you, or anything you thought I didn't understand? Is there anything you want to make sure and do differently next time? And it's so important to get feedback from patients. And the first thing that we say when patients give us negative feedback, either during the session or at the end of the session, we have to say, oh, it's good you told me that. And it is good, because if there's a problem, you need to know what it is so you can then collaboratively solve that problem.
You can also enhance the therapeutic relationship, that this is the open space when we can share also a difficult thoughts and the problems, but we want to solve them. So that's
exactly
as I understand it.
Yeah. So cognitive conceptualization, therapeutic relationship structure.
Yeah. So the most important things about the skills of the cognitive behavioral psychotherapist. And maybe the other question, from your experience as a supervisor, what are the most common mistakes that therapists do? Because this is the opposite side. Yeah.
Also. So I would say the biggest mistake is not adapting the treatment so that it is acceptable and helpful to the individual client. So, for example, in the United States, there are clients who have a different ethnicity from me. And it's very important, for example, for me to ask certain clients, have you experienced racism in your life? And do you think that there's any connection between the racism that you have experienced and the difficulties that you're having today? It's very important to adapt treatment, whether you have a young child you're working with, or an adolescent, or an adult, or an older adult. It's important to be aware of the client's culture and what kind of cultural beliefs might be getting in the way of the client being able to reach their aspirations or live in alignment with their values. So there are just so many different ways that CBT needs to be adapted. The structure that I just talked about, is wonderful for most clients. And then there are other clients who really object to it. And so then I think it's really important to ask clients, well, what do you think would help you more? And then to ask the client if the client perhaps is willing to split the session and talk about the issues that the client wants to talk about, perhaps in an unstructured way for part of the session. And then in another part of the session, just do an experiment of trying to talk about either it or another problem in a more structured way to see whether that would be helpful to the client.
Yeah, so those cultural differences, they are very important. Yeah, and I think especially now in Poland, when we have like a lot of refugees from the Ukraine, so to know the culture, we as a psychotherapist, like this is very important.
Yes, very important.
My next question would be connected with the new cognitive behavioral psychotherapy, the recovery-oriented CBT, because I think for many therapists in Poland, it would be something new. And what is like the most important features or the elements of the recovery-oriented CBT, and for which disorders, problems it is like most applied?
Yes. So recovery-oriented cognitive therapy, I'm going to just call it CTR from now on,
okay.
was developed by my dad and Paul Grant, who's now at the Beck Institute, for individuals who are diagnosed with serious mental health conditions like schizophrenia and bipolar disorder. And they've developed this treatment, and it doesn't really matter whether the person is living at home, maybe with some community support, or whether the individual has been in a psychiatric hospital for 20 or 30 or even 40 years. The principles are the same. And also, these CTR principles are ones that I have integrated into CBT for outpatients. And in Cognitive Behavior Therapy Basics and Beyond, just the third edition, 2021, I've integrated the principles throughout that book. For serious mental health conditions, if some of the therapists are working with that population, then a book to take a look at was by my father and Paul Grant and colleagues called Recovery-Oriented Cognitive Therapy for Serious Mental Health Conditions. So my dad and Paul started to develop this treatment about 20 years ago. And what's so fascinating to me is that my father, who was then, he was about 80 years old at the time, maybe 82 years old, was able to take a fresh look at schizophrenia and bipolar disorder and formulate the conceptualization in a different way. So they recognized that when patients are in a psychotic episode, they are in what they call a maladaptive mode. So their beliefs are very negative. Their emotions may be intensely negative. They make negative predictions about their future. And it makes sense with the activation of all of their negative beliefs that they would then act in a way that's not very helpful. Isolation, withdrawing from people, inactivity, and sometimes aggression. Now, I think that they probably at that point were familiar with some research, which is very interesting, that shows that when you focus on people's psychopathology, you can, using CBT, you can reduce their psychopathology. You can help them feel less depressed. You can help their thinking be less inaccurate and so forth. But it doesn't necessarily lead to positive emotion. And CBT, little p, CBT for psychosis, really focuses on patients' psychopathology. Their negative symptoms like apathy and their positive symptoms like hallucinations and delusions. And they've had a certain amount of success with that, particularly with people, I think, on an outpatient basis. But what my dad and Paul discovered was that a better route to take might be to help patients increase their positive beliefs. And so the first task is to engage the patient so that he's willing to talk to the therapist. And they do this by providing some positive experiences. So the therapist might ask the patient for some advice, like what kind of record or music should they get for their aunt, or what kind of presents should they get for their 5-year-old son. You know, it depends on how old the patient is and what the patient's interests are. And then they start to engage in positive experiences together. So they might play music, they might dance together, they might go to music group together, they might take a walk together in nature, they might play basketball, they might go to McDonald's and get a hamburger. The way that the therapist knows what kinds of activities to arrange is by asking the staff of the hospital or wherever the patient is living When is this patient at his best? What kind of activities does he seem to enjoy? What emotions do you think he's experiencing during those um, activities? What kind of positive automatic thoughts do you think the patient is having? So over time, the therapist continues to engage in positive experiences with the patient and then helps the patient draw positive conclusions to help them increase the intensity of their positive beliefs. So initially, the therapist might ask yes, no questions, such as, did you enjoy yourself? Did you have more energy than you thought you would? Did did you do a good job in this activity, better than you expected that you would do? That kind of thing. And then over time, they turn to helping the patient draw his own conclusions. So what did you think of the fact that you were able to make 3 baskets in a row? What does it mean that you were able to help this other patient learn how to do some math so he could take this special test to get a high school diploma and so forth? And so it's so interesting. Instead of focusing on the psychopathology, they really focus on providing experiences so patients can increase their positive beliefs. They also help them identify their aspirations. What do they really want for their lives? How do they want their lives to be? And help them identify their values. Now, sometimes their aspirations are delusional, like I want to be king of the world. And in that case, the therapist asks the patient, what would be good about being king of the world? What would that mean to you? And then the patient usually says the same kinds of meanings that you and I would want for ourselves. Well, it would mean that I was in control of my life. It would mean that I could help other people. It would mean that I could do good things for the world. And then what the therapist does is to help them figure out what are some activities that they could do even when they're still in the hospital to take more control of their life, to help other people, to do some good deeds and so forth. And so instead of focusing on the psychopathology, the therapist is focusing on helping the patient have a better sense of safety, a sense of competence and control, a sense of purpose and meaning in the patient's life, and so forth. And they'll use more standard CBT techniques when they get to challenges that the patient might experience in taking some steps in alignment with their values and their aspirations in the coming week. And again, these problems might be either just some problems that need some problem solving, or they might be automatic thoughts that get in the way. They may be psychotic symptoms that get in the way. And then they might use some regular CBT to help solve those problems so the patients can have a better week. So that's kind of it in a nutshell. And when we apply this to outpatients, one of the things that we would do is to try to get the patient to experience positive emotion right in the session itself. One way of doing that is by asking them what they did in the previous week, or what experiences did they have that where they felt better than maybe some other times, and then helping them draw some positive conclusions about these better experiences. That's just one way of integrating these principles.
I think that it also shows, on the one hand, that how, in general, activation, but connected with the patient's values is important, but also I think the relationship here, the collaborative relationship, the patient with the therapist, that I think that it also could be very influential, that they are working together, they are playing, dancing together. I think that it must be very important factor at that moment.
Absolutely. Yeah. And what the therapist is really doing is inviting the patient along to do very normal human everyday activities.
Next questions would be also, it's I think, connected with recovery-oriented CBT. And like we all know that your late father, Aaron T. Beck, was an incredibly creative researcher and scientist. And how did he envision the future of cognitive behavioral therapy before his passing? Did he have any specific visions or planned project? I think that maybe CTR were one of them, but yeah, maybe some others would.
He predicted that eventually there might only be one psychotherapy, and this psychotherapy would draw on techniques from any of the other modalities. And he thought that probably this psychotherapy would be based on the cognitive model, that people would develop a cognitive conceptualization, and that the therapy would become more and more effective the more that research is done, both kind of more basic neuroscience research as well as outcome treatment research. It's to help us figure out what or how treatment might be oriented to fit a particular patient. But he said if it turned out that there was a greater research basis for a different psychotherapy conceptualization, then that's what should endure and not CBT. So he, from the very beginning was very research and scientifically oriented. And he also really valued the adaptation of CBT or CTR for the individual.
You are an author of numerous articles in renowned scientific journals and books on CBT. Like many of them also have been published in Poland. And I am currently reading the book, The Cognitive Therapy for Challenging Problems, What to Do When Basics Don't Work. Yeah, and like from your experience, like on the one hand, like could you share a context of the creation of this book, and whether from your experience, there are any particular elements that we should pay attention to when the basics don't work?
Sure. So the reason I wrote the book was because I got a lot of feedback after I wrote Cognitive Behavior Therapy Basics and Beyond. People kept on saying, but the patient that you used was so straightforward. She was a college student. I can see how CBT works with easier patients, but how about the more difficult patients? And I have to say that I did listen to the feedback, and in the third edition of Cognitive Behavior Therapy Basics and Beyond, I do use a much more difficult patient who is depressed, and I also follow a patient with borderline personality traits throughout the book as well. Anyway, so I knew that there needed to be a sequel, another book that talked about patients who were more difficult. And at that time, I was giving many, many, many workshops each year in person. And one of the topics was how to treat individuals using CBT, but individuals who had personality disorders. But it didn't really matter what the topic was. It could have been depression, could have been anxiety, could have been any number of topics. I would always ask at the beginning of the session, at the beginning of the workshop, what problems have you been having with patients with this diagnosis? And so I had a very long list of problems that were not addressed in the first book. And then it took me about 5 years to figure out how to organize that material. Once I figured it out, then it only took me 2 years to write the book. But I realized that in so many of the problems, the problem was occurring because of a problem in the therapeutic relationship, or the problem was arising because the therapist hadn't correctly conceptualized the patient. So I realized those needed to be the first two chapters. And in fact, if anyone who's listening is having a problem with a patient, I would ask you to think to yourself, have I conceptualized this patient right? And is my relationship with the patient strong enough? Because if either of those things isn't good enough, then that's where you would need to start to improve something. And then I was more easily able to organize the information after that. So there's a chapter on problems with structuring sessions, problems with getting clients to do their homework, which we now call action plans, problems with identifying and responding to automatic thoughts, problems with modifying core beliefs, and so forth. And I was able for each of the chapters to come up with some specific examples, and then I would conceptualize each problem and then talk about and often have a transcript of what you could do to solve that problem.
When I teach some students as a supervisor, I always saying that this is a very important book. Before we start to search another technique or something, that we should come back to the conceptualization, and I always refer this book because it's also very, very important.
Thank you.
What is your stance and what do you think about those third wave CBT therapies? What do you think about it, and do you think that we can integrate, or how to integrate, in a very natural way, for example, ACT into the CBT? What do you think about it?
So acceptance and commitment therapy, there are several aspects to that I think should be integrated into CBT for any patient. One is their emphasis on values and helping people become motivated by these values, to do the kind of the hard work of treatment, and also the steps that they need to take between sessions. If you help them understand how those things are connected to what's most important to them, then they're more likely to go ahead and do them. So that's one. Another part of acceptance and commitment therapy, which is very important, is to help patients when they are engaged in an unhelpful thought process, such as depressive rumination or anxious obsession, or just streams of critical automatic thoughts about themselves. So when patients are engaged in one of these dysfunctional thought processes, it usually doesn't help to go after one automatic thought because another one just will pop up, go after that, and then another one will pop up. Instead, we have to teach them how to disengage from the thought process. And the ACT techniques can be very useful. And what we want to have them do is just to recognize that they're caught up in this cycle of thinking, and then use some mindfulness techniques in a non-judgmental way, and bring their attention back to either what they want to be thinking about, or bring it back to their breath, or a body scan, or a focus on an external object, or in the case of someone who has just streams of self-critical automatic thoughts, is to do a self-compassion kind of mindfulness exercise. So those are just two of the ways that we integrate ACT concepts. ACT also has some really wonderful metaphors that we use with patients too.
I think also those things, they are also related with conceptualization. Yeah, what is the problem? So it's always like for me like the basic question, and like those methods would be just the another ways to like, try to tailor the therapy for the specific patient. Yeah,
that's right.
Okay, and what books have shaped you as a therapist? They can be both professional, but also non-professional.
Oh gosh, there's so many. Let me think where to start. Well, you know, the first treatment book that my father and co-authors wrote, Cognitive Therapy of Depression, which was 1979, was really where I got my start in CBT. And in recent years, I've been reading more books about how to adapt CBT to the individual, books about the therapeutic relationship, books about personality disorders, and gosh, there was another topic that I was thinking of. I can't really remember it right now. Oh, of course, books about recovery-oriented cognitive therapy. That's probably been the most influential for me in the last few years.
There are any factors that have influenced like the development of Judith Beck as a therapy scientist? Like what were your inspirations and motivations? And like from now, how do you see a future of CBT?
So I'm really passionate about good CBT, and I'm passionate about helping therapists learn how to deliver CBT in the most effective way. And, you know, there are certainly times when CBT plus medication might be better for a given patient. On the other hand, the problems with medication, one problem with medication is that the patient generally doesn't learn skills. And, you know, I think it's one of the most important ingredients of CBT is our focus, no matter what the problem is, on relapse prevention. I just think that is so crucial. What I think the future is, well, a lot of it is a continuation of what has already started. I think artificial intelligence is really going to help. I think there is going to be, I think we may be 5 or 10 years away from it, but I think eventually there will be really terrific AI treatment apps or computer programs that will help just millions and millions and millions more people get CBT treatment. And probably the role of psychologists and psychiatrists is going to change, where we only see patients with the most severe problems who don't benefit from some kind of computer program or app or something like that. There are some apps and computer programs already that use AI, and they're pretty good. And I think that they will just get better. Another change that I see in the future is different delivery programs. So in Zimbabwe, for example, they teach the elder women in a village how to do some very basic CBT, like problem solving and behavioral activation. And instead of, these are not necessarily trained counselors. They're kind of wise women. And they don't have an office. They sit on a bench, a community bench. And then members of the community, I think especially women, come and sit on the bench. And they kind of get CBT that way. And this kind of paraprofessional or lay leader may also then try to get the patient to join some kind of self-help group or something like that as well. There's some interesting research in Pakistan that showed that you could train lay counselors to work in primary care. So this is the primary care doctors to give CBT to depressed women. I think that we're going to see more and more and more of the integration of CBT with medical problems. And more than 50% of patients who go to see their primary care doctor actually have mental health problems. And I think that it's very slow in coming in the United States. I think it's better in the UK and in some other countries, but I think we're going to see more and more either CBT therapists in medical offices, or we're going to see medical personnel like nurses and physician's assistants who are going to be trained in to use some CBT techniques. And so that's just some of the future directions. I think eventually that individual cognitive behavior therapists will start to use many more CTR kinds of techniques in their work as well.
Great, thank you. Yeah, it shows how CBT is like multicultural and how it's like a complete approach like to the human, to our like cognitive system, like how it can be applied in I think every state of the mind in any problem. Yeah, it's wow, it's such a like a gift, such a great thing. So I know that our time is finishing. Like it was like a great honor and a big pleasure. Also, I would like to, I have so many topics that I would like to ask that probably will never stop. So I think that it would be a good point to finish. So like, Dr. Beck, thank you so much for joining us to share your knowledge, your experiences, your from my heart. Thank you very much.
My pleasure. Thank you for inviting me.